Hi everyone. This week we're going to learn about case finding. However, before we start discussing case finding, let's review last week's reading assignment. In Chapter 1, you learned about the different types of cancer registries. Specifically, there was the hospital cancer registries, which maintain the data on all patients diagnosed and/or treated for cancer at their facilities. The primary goal for this type of registry is to improve patient care by evaluating the treatment outcomes of their patients. They collect data about the diagnosis, treatment, and recurrence of their cancer and the survival of those patients. This data is then submitted to the state central registries, and if the facility is a COC accredited or Commission on Cancer accredited facility, then their data is also submitted to the National Cancer Database or NCDB. Another type of cancer registry is the population-based cancer registries, which collect data on all cancer cases in a defined population, such as the state, country, or region, such as American Indian tribal community would be an example of a region. This type of registry is designed to determine cancer patterns among various populations, to monitor cancer trends over time, and to advance clinical, epidemiological, and health services research. Okay, for state central registries, it depends on the type of state registry they are, but they either submit their data to the Surveillance Epidemiology and End Results, or SEER program, or the National Program of Cancer Registries, or NPCR, and some states have to report their data to both of these organizations. Now, the third type of cancer registry is the specialty cancer registries, which are established to collect and maintain data from specific facilities, such as the COC National Cancer Database, on a particular type of cancer or tumor, such as the Central Brain Tumor Registries of the United States, or to collect data on familial cancers, such as the Gilda Radner Familial Ovarian Cancer Registry. That's quite the mouthful. These are the most known specialty cancer registries, but there are many others out there, as are listed on the screen here. Now, the purpose of these specialty registries can be to provide advocacy, educational opportunities, and to support those who suffer or have family members that suffer from the disease. This chapter also introduced the importance of data standardization. One of the fundamental necessities of cancer surveillance is for uses of the cancer data that is collected and be assured that cancer definitions, coding practices, and conversions of medical terminology is standardized. This enables the compilation of cancer-specific information into useful and meaningful data. It also enables meaningful comparison of data across the different registries. All right, so the goal of cancer registry data standardization is to set standards and build consensus for the collection of uniform cancer data across the entire world. Okay, and in order to do this, the professional and standard setting organizations need to work together to develop uniform data standards for cancer registry for both hospital and population-based registries. This is the list of the standard setting organizations of cancer information management profession. You will learn more about each of these in this course, as well as other courses within the SIM program. Now on to this week's reading assignment on case finding. Case finding is a system for locating every patient, whether the encounter was as an inpatient or an outpatient, who was diagnosed and or treated with a reportable diagnosis at your facility. All registries must perform case finding. Although cancer registries may use different source documents to identify cases, the procedures involved in case finding are very similar. Now, the goal of case finding for both a hospital and a state central registry is to identify and report all reportable cases and accession them into the registry. When we state that the case is accessioned, that means that we enter it into the cancer registry database and abstract it. The reportable list that we use to determine what cases are reportable is the governing document for case finding in the cancer registry. Almost all malignant cases must be reported to the state. A couple of the malignant cancers that are not reportable are squamous cell and basal cell carcinomas of the skin. Okay, those are not reportable. There are benign central nervous system tumors, including brain tumors, that are required by law to be reported. Okay, so we have malignant cases that aren't reportable, and then we have benign tumors that are required to be reported. Some central registries may require the registry to report other benign, borderline, or uncertain behavior cases. An example of a borderline tumor would be what they call a borderline ovarian tumor or a thymoma. Those are two examples of borderline or uncertain tumors that are not reportable, but some states may require them to be reported. A hospital cancer committee may also decide to accession or collect cases that are borderline or have uncertain behaviors into their registry. These cases are referred to as reportable by agreement. Now, state reportable by agreement cases would not be reported or submitted to the National Cancer Database or NCDB. And the Cancer Committee reportable by agreement cases would not be submitted to the state or the NCDB. Those would just be collected and followed for their own purposes. Each year, a reportable list is published. The list coincides with the release of the ICD-10 CM code updates. Here's a portion of this year's list. As you can see, the format of the list has changed quite a bit from the example that they have in the textbook from 2009. First of all, we're now at ICD-10 and they were at ICD-9, and the format has changed a little bit. They've done more ranges than each one listed separately. This list is what you would give to your IT department to write and run a report to list all patients that had an encounter at your facility with one or more of these codes. Okay, so you would give this list to them, and then they write this report, and each month they would run the report and give you a list of all the patients that had an encounter at your facility with one or more of these codes. If your state requires additional tumors be reported to them, that list would be available in their coding manual, okay? So as a hospital cancer registry, you would also have to check with your state manual to make sure that any cases that aren't normally on this list would be added to the list that you give to your IT. We will not go into specifics of what Wisconsin or your state requires that are not listed in this reportable list. Remember, we are just learning the basics of this course. Next semester, we will identify cases that your state may require you to report that are not listed here and perform case finding at your facility. So we will investigate each of your state's registries to determine if they do require cases be reported that are not on this list. The most important thing for you to remember right now for this course is why we do case finding, the general process, the methods of the case finding, sources utilized, and the importance of case finding. There are two types of case finding methods used by registries, active and passive. Now, active case finding involves registry personnel retrieving source documents such as pathology reports or radiation oncology reports. The benefit of active case finding procedures is that this method is more thorough and accurate than passive case finding. Registry personnel have knowledge of criteria and terminology to recognize reportable cases. Now, passive case finding occurs when other departments notify the registrar of potentially reportable cases. A concern with passive case finding is that non-registry staff are not as familiar with reporting criteria and terminology. So potential cases may be missed and incomplete case finding may occur. For some registries, a combination of active and passive case finding is commonly used. Various sources are used for case finding. The main source is pathology reports, which includes surgical pathology, biopsies, cytology, bone marrows, and autopsy reports. For radiation oncology, treatment summaries and new patient listings are valuable sources for case finding as well. Surgery schedules and reports can be used as sources to identify port placements or seed implants for prostate cancers. Logs for cancer-specific outpatient areas or clinics, such as chemotherapy clinics, are important to include in your case finding procedures as well. Now, the computerized disease index based upon the cancer codes, which we just discussed, is another main source of case finding. So the inpatient chemotherapy and clinically diagnosed cases by radiology are some of the cases that would be found using the disease index. Okay, so cancer registrars rely on the coders to accurately code hospital encounters to find these less obvious reportable cases. So we as registrars really depend on those coders to make sure that they accurately code each encounter for the patient, because if they inaccurately code that patient's encounter, it might not get onto our disease index list, and it may be listed through our case finding process. The two most important case finding sources for both the hospital and the state central registry are pathology reports and the disease index. This is due to the fact that these two sources identify most of the cases that are required to be reported. Now, non-hospital specific case finding sources include freestanding pathology labs that are not affiliated or owned by a hospital. Dermatology clinics, even though they are supposed to report their cases to the state, sometimes do not. More and more dermatology clinics have their own pathologist right on site. Therefore, the state registry has to develop a process or processes to ensure they receive these cases from these clinics. Now, disease indices from freestanding surgery centers, radiation, and medical oncology clinics can be utilized by the state central registry or by a hospital. If the hospital owns these clinics, then it is their responsibility to report any cases that may be diagnosed and or treated at these clinics. So if your hospital owns a surgery center that's not connected to the hospital itself, but they own that, your hospital, your organization is still required and responsible for reporting those cases. Now, death certificates and out-of-state data exchange case finding sources are utilized by state central registries and not by hospital registries. And we'll learn more about that in a different course. Now, let's walk through the case finding process when you're looking at the pathology reports. Okay, so you take the pathology report and you look the patients up in the cancer registry database. Okay, if the patient is in the database for the same primary site, then the follow-up on that patient may be completed using that pathology. Oh my goodness. My flow chart. Oops, sorry. I went one too far. I didn't realize that would. Okay, there it is. Thought it would all pop up at once. My apologies. Okay, let's start over here. So we take the pathology report that's in front of us. We look to see if the patient is, first of all, look at the path report to see if this path report has a histology that is reportable. Now remember, if it's a pathology report of a skin excision and it's squamous cell or basal cell of the skin, it's not a reportable histology. So we do not enter that pathology report or even look up that patient in our database. It's not a reportable histology, so you can go ahead and toss that pathology report. All right? So if the histology is a reportable histology, say adenocarcinoma of the prostate, then you would look up that patient in your database. Okay? So if the patient is in your database for that prostate cancer, you can go ahead and update that abstract with that information that you have on that patient, and then you'd be done and you would go to the next report. Now, if that patient was not in your database, then you would enter that patient into the database and go on to the next report. Okay, and when we enter that patient into the database, we enter them into what we call suspense, where that patient will sit until an abstractor can go ahead and abstract that case. And then you just go on to the next report, and the cycle goes over and over and over with each one of the pathology reports. Oh, now it's all going backwards. Oh, that's because I'm on my arrow. Well, technology, you gotta love it, right? All right, let's get this all together. Hopefully I won't go too far. All right, so each month you're gonna receive this disease index list from your IT, okay? So it's gonna have all the patients that had an encounter at your facility from the first of the month of whatever month you're looking at until the last day of that month. All right, so you take that list and you look up the first patient listed and see if they're in the database. Okay, if they are in the database, then you just go on to the next patient and look up and see if that patient's in the database. All right. Now, if that patient is not in your database, then you would have to review any and all encounters that that patient had in your medical records for that time period, okay? And determine, is it a reportable case, okay? Reasons that it might not be reportable would be that the patient just had a lab report, or they came in for a mammogram, but they have a cancer diagnosis of the breast, or anything like that. Or in my case, our clinics are also associated with our hospital, so it just might be a regular annual checkup, okay? So if the patient had no active disease diagnosis or treatment of a cancer, then it's not a reportable case, and I would go on to the next patient. Now, a reason that it would be a case is if the patient had, let's say, an MRI of the brain, okay, and they were experiencing migraines. They went in, had an MRI of the brain, and the MRI actually showed this incidental meningioma. Now, meningiomas are a benign lesion. However, it's a benign lesion of the brain, and those we are required to enter and report and make an abstract for. So that patient would be entered into the database. So meningiomas are not usually surgically resected. So even though they probably won't go on to have any treatment, they are diagnosed with this reportable case. So we must enter that patient into the database and then abstract it. So there are other times that a cancer can be radiologically diagnosed. Sometimes an elderly person might show up in the ER with shortness of breath, and they do a CT scan and show this large lung mass that definitely looks like cancer, very, very suspicious for cancer. But because they're 90 years old, they don't really care if they have cancer or not. They don't want to know if they have cancer. Even if they did a biopsy to prove that they had cancer, they wouldn't want to have any treatment. Therefore, it would still be a case because the CT showed this suspicious cancer, okay? So once again, we wouldn't be able to find this case through a pathology report. So those are the types of cases that we find through the disease index. Other times, if a patient is diagnosed elsewhere and then would come to your hospital and have chemotherapy, my program where I work, we have a pediatric oncology clinic. So a lot of those patients are diagnosed elsewhere, but then they come to our hospital and have inpatient chemotherapy. So once again, I won't be able to find that case through a pathology report because there wasn't one done at our facility. However, they were treated with chemotherapy treatment. We must report that case. So that's how I would find that case through the disease index. Okay, I know that's a lot to take in, but big overview of case finding process. You will work next semester and actually do case finding and go through that process. Remember, right now, just an overview of the main functions of the cancer registry and the cancer management as a whole. So once we determine that the case is reportable, like I said, we accession it. Okay, we enter it into suspense where it sits there until an abstractor can abstract that case. Now, the importance of case finding is to ensure complete reporting to both the state and to NCDB if you're COC accredited. Now, quality control procedures should be implemented to guarantee all cases are captured and reported. Completeness logs can be utilized to monitor the number of cases found. Multiple completeness logs can be used. For example, the number of cases by month or by department or by year or even by cancer sites. All right, I'll show you some examples in a moment. By comparing the different monthly or annual reports, you can identify underreporting areas so that immediate corrections can be made. Make sure that case finding procedures are doing what they need to be doing. Now, completing case finding processes to ensure complete reporting is important, but it is also important to make sure that this process is done in a timely manner, okay? Because to ensure timely abstracting, the case finding must be completed in a timely manner as well. If you're doing case finding 6 months out, then your abstracts are going to be older than 6 months by the time you abstract them. Here's an example of a completeness log. The table monitors the number of cases that were accessioned or entered into your registry each month for the past 2 years. There are many different reasons that numbers can fluctuate, but as a quality control, it should be determined what that reason was to verify that the number of cases accessioned is truly correct. Now, the steady increase of cases could be due to a new physician or physician specialty that you did not have previously. So these are good things when your numbers go up. For example, at our institution, when we didn't have a GYN oncologist, all of our GYN cases were referred to a facility that had one, more of a tertiary, larger facility that had a GYN oncologist on staff. Once we hired a GYN oncologist, our numbers increased by more than 100 cases that next year. Or it could be the opposite, where a specialty physician actually leaves your institution, okay? Sometimes it is easy to identify why the number of cases may have gone up or down, but when the reason is not easily identified, a process must be in place to verify that the number of cases you have accessioned are truly correct, okay? So the best way to accomplish this is to request a new disease indices, again, for the months in question from your IT department. Okay, make sure they rerun that report, you redo that case finding through the disease index. Now, each week, I will end the presentation with key points. There is so much information in the textbook, and to be honest, you may not be required to know all of it to perform your job, and you will not need to know all of that information to actually sit for the exam. So to assist you in knowing what you really, really need to know and remember, I will point out in the key points at the end of each presentation. All right? So the case finding key points you need to know and remember are what the goal of case finding is, the general process of case finding methods, sources that we utilize by either the hospital or state central registries, and then the importance of case finding, okay? So once again, what the goal of the case finding is, the general process of case finding methods, Case finding sources utilized both by the hospitals and the state central registries, and what one may use and the other may not. And then, of course, the importance of case finding. I hope you enjoyed today's presentation. If you do have any questions, please remember to post them in the virtual office. Have a great week, and we'll talk to you again next week.